Okay, fine, man. Thank you so much. And I'll be in touch. Okay. Hi, guys. So the finish line is approaching very soon. And I think that you are in the right frame of mind for tackling this exam spot on. Hi, Nadeem, Yash, Muhammad Aman, Jivendra, Shashikant, Vyas. Good to interact with all of you. And the first message is stop overthinking. Start. I'll move towards my left. Start doing. That's one of the most important messages for today. I would like you to sit with intent, focus on the studies, and I would also request you that if you have any doubts, then try to keep them towards like end of 1 hour of the discussion, because then I'll be in a flow to study. Otherwise, what happens is that the flow tends to get interrupted, and those who are having good, I would say good flow, they tend to feel a little distracted. So I will keep on answering all of your queries. Don't worry, right? But what I would request you is if you can not immediately, because see, as a teacher my job is to satisfy everybody. So what happens is that when you moment you put up a ping, I try to answer immediately, and that results in like the upsetting of the rhythm for the actual class. So yep, you have the PDF with you. Underline, annotate, question every line. पढ़ने का मूड तो देखो बनाना पड़ता है. Watching a movie is something which everybody would be going with intent, and everybody would not mind paying like 1,000 rupees for a ticket for an ambience and everything. But study is something where you don't have ambience, you just have your room to yourself, and you need to keep focusing. So Ram Ram Neeraj, hi Dr. Shams, hello Dr. Mayuri, good to interact with all of you. And yep, you should be standing out right on the top when the result would come subsequently in the month of July. But to make that month of July happening, it's the focus at the moment that would really, really matter. Okay, Nitish, keep hammering. Tushar, good afternoon. Chalo ji. Fine, let's get started. So, Abhi, the first hour is where we focus to get the rhythm into like JCR. Hi, good evening, good afternoon. Hemant, now let I might have missed a couple of names. Please excuse me for that because I got teaching to do. So I have a question for you guys, and I would like you to comment on the answer to this question immediately. This is just to get the rhythm going and to tell you the kind of things and the questions that are asked in the exam. So trauma patient is emergency admitted to the emergency room. You can notice a lot of bruising over the chest wall. There's a tachycardia. The blood pressure of the patient is decreasing. That is seriously a cause of concern. And then he's telling me that there is a dullness to percussion present. More importantly, he's telling me there are distant breath sounds which are present. So my clinical diagnosis in this particular case is hemothorax. Guys, all of you are answering B in this chat. Please understand, in pneumothorax, there will always be a presence of hyper-resonant percussion note. There would be absent air entry, absent breath sounds, and there would be elevated JVP, not collapsed neck veins. पढ़ो ना इसको ध्यान से. Collapsed neck veins means that the guy is losing blood. I did not say the fact that he is having any obstructive shock manifestations. The patient is having hemothorax. For confirmation of hemothorax, you need to do a urgent chest X-ray in the patient. बेटा पेरिकार्डियोसेंटिसिस कैसे हो जाएगा? पेरिकार्डियोसेंटिसिस के लिए क्या लिखा होना चाहिए? आपको मैंने पढ़ाया हुआ है ना कि फॉर पेरिकार्डियोसेंटिसिस द पेशेंट शुड बी हैविंग मफल्ड हार्ट साउंड्स, ही शुड बी हैविंग hypotension, he should be having elevated JVP. I think everybody has studied this fact. Muffled heart sounds, hypotension, elevated JVP, that is non-pulsatile, is a feature. क्या इस क्वेश्चन में कहीं लिखा है muffled heart sounds? कहीं यहाँ पर लिखा है elevated JVP? नहीं ना. The answer is not B, C or D. Please evaluate. सीधा assume मत करा करो that this is an answer to a question. The correct answer to this question is option number A, that would be chest X-ray. आप question फिर से पढ़ो. The patient is presented with bruising over the left chest wall in this particular individual. And if I'm gonna give up this kind of a presentation before you, then what I can say is that whenever you will auscultate the patient, you will be able to notice inframammary, infraaxillary areas. There would be dullness to percussion in a patient. Now, that is one of the core things that I want you to pick up, that there is a decrease in the JVP. In fact, I would not like to say decrease in the JVP. He has written the word collapsed veins in the chest. क्यों? क्योंकि blood loss हो रहा है patient को internally. So the diagnosis of this particular patient is hemothorax, and therefore chest X-ray would be required. Somebody said, बेटा आपने बोला कि no need of chest X-ray. That is for if the patient is having tension pneumothorax. अगर इस क्वेश्चन में लिखा होता hyper resonant percussion, absent air entry, absent breath sounds, elevated JVP, mediastinal shift, any of those statements that I've taught you, then the answer will have obviously changed over to a wide bore needle in the fifth intercostal space of the patient. So I think we are sorted for the first question. That was just to get the rhythm going. So if you got it wrong, कोई टेंशन की बात नहीं है. अभी गलतियां करोगे तो आगे गलती नहीं होगी ना. आपने एज्यूम नहीं करना है. न्यूमोथोरैक्स भी हो सकता है, हेमोथोरैक्स भी हो सकता है, हेमो न्यूमोथोरैक्स भी हो सकता है. सो वी आर गोना लर्न द टिप्स एंड द ट्रिक्स टू बी एबल टू सॉल्व द क्वेश्चन. लेट्स गेट गोइंग. First and foremost, I would like everybody to comment on like the options or like the correct answers to this one. We'll talk about the ABCD of pulse, that is anacrotic pulse and pulsus alternates. When you read the word anacrotic, anacrotic will rhyme with what? Obstruction, aortic stenosis. You know, if you just say the word yourself, एक बार बोल के देखो, just say the word anacrotic and then say the word aortic, you will realize the fact that both of them basically rhyme together. So a physical obstruction is going to be responsible for anacrotic pulse. But pulsus alternates, this is like a failing heart. It is the last ditch effort that it is trying to do. So you will have alternatively weak and a strong pulse, alternatively weak and a strong pulse. And therefore your answer in this case would be left ventricle failure. Very simple and straightforward. Two pulses beginning with A, L, the anacrotic pulse and alternates pulse in a patient. Very good. I had good comments for this one. Now I will focus on why not pericardiocentesis. Beta explained now there is gonna be muffled heart sounds for a hemopericardium. The question was not on hemopericardium. Moving ahead. Pulsus bisphareus. Neeraj was the first one immediately, like he commented on this one, and this is the pulse that was coming in last time's paper also. Pulsus bisphareus is a jerky pulse. That jerky pulse is due to again a physical obstruction below the level of the aortic valve. So I will be discussing cardiomyopathies in the later part of today's discussion, but at the moment it is hypertrophic cardiomyopathy for pulsus bisphareus. The alternative name for this condition is subvalvular aortic stenosis. Now we come to twice beating pulse. Very good. Bisphareus by word is a twice beating pulse. So I will show you line diagram also. The next question that has been asked is like, I know you will kill this question. This is so commonly frequently asked in the exam that you read the word pistol shot sounds that are auscultated over the femoral artery and the collapsing pulse in a patient, also called as water hammer pulse. Very good, beta. The answer for this condition would be given as valvular aortic regurgitation. That is, blood is coming back in the heart, and he might even show you a schematic in which the blood is, like you can see, if you raise the arm of somebody above the level of the head, the blood will not leak back into the cardiac chambers, but in this patient it is. So, yep, pistol shot sounds very classical for valvular aortic regurgitation. Now, since all of you have studied this, I will add two more points here that I want you to remember. Lots of time in the question of valvular aortic stenosis, he may write the word dancing carotids. Why the carotids are dancing? Because of the to and the fro movement that is occurring in the blood vessels. In contrast, questions of aortic stenosis, because there's a stenosis now, so there would be a turbulence. For that turbulence, he will use the word carotid thrill. So don't assume that in the question they'll simply put up words like anacrotic pulse. He may say carotid thrill is seen in, then thrill matlab palpable murmur. That means turbulence. That turbulence comes because of a physical obstruction present. But if he says dancing carotid in a patient, the dancing carotid, the to and fro movement, that's going to be a feature of aortic regurgitation, where we also got Quincke's sign, that is pulsations in the nail beds of the patient. And in last time's paper, though that was not the answer to the question did mention pulsations in the nail bed. That pulsations in nail bed is called as Quincke's sign. Now we come to dicrotic pulse. Dicrotic pulse is a feature that is seen in dilated cardiomyopathy. The highlight of this pulse is, however, it is again twice beating, but one part of the peak is in systole and the second part of the peak is in diastole. So we are sorted with ABCD for this one. Very good, very good, very good. I think most guys have got it spot on for this one. And now we touch upon pulsus paradoxus. This is actually a misnomer. Pulsus paradoxus can be seen in pregnancy also. Don't be surprised if he says the word pulsus paradoxus in pregnancy. It looks like a very hi-fi word, but it is actually not. Standard cardiac conditions that cause pulsus paradoxus, where the systolic blood pressure falls more than 12 millimeter on deep inspiration. In you and me also, blood pressure will fall on deep inspiration, but here the fall will be more than 12 millimeters. Two cardiac conditions which will be associated are tamponade and constrictive pericarditis. You know them very well. So वो जानबूझ के he will ask you respiratory conditions. The respiratory conditions that can be resulting in this are massive pulmonary embolism, that's a clot in the pulmonary artery, inferior wall MI, and asthma. If you look at these two conditions, in both of them, the common thing is right ventricle is getting damaged. Massive pulmonary embolism, pulmonary artery is blocked, right ventricle will fail, right ventricular MI, ischemic damage will be occurring. So you also have to remember that pulsus paradoxus can also be seen in right ventricular damage, and sometimes to exaggerate, just correcting you, it is not asthma, it is severe acute asthma going into impending respiratory failure, that is status asthmaticus. Nowadays, we don't use this term. Status asthmaticus is also called as silent chest. So what I'm saying next is, don't be surprised if he says the word silent chest and examination finding is pulsus paradoxus. Yes, it is one of the findings that can be seen in these patients. Not that it will be an MCQ. Silent chest question will talk about your knowledge about management of asthma. But in the examination findings in the question, he will deliberately mention the word pulsus paradoxus because he wants you to think in terms of cardiovascular disease. The patient is not having a cardiovascular problem. It's like a silent chest that is happening. So for silent chest, I just want to say it will not be an answer to the question, but it will be one of the examination finding, a distraction given in the question. Now we come to irregular pulse. Nadeem was the first one to hit the comment button for the same. Yes, today I want you to be the fastest to hit the comment buttons. Why? Because that tells you that you are actively participating. When you use your neocortex, when you use your hippocampus, when you use a temporal, parietal and occipital lobe, your brain is firing on cylinders. Think of yourself as a Formula One car today with a nitro boost. Right? That's gonna pump on the accelerator. Very good. Atrial fibrillation and multifocal atrial tachycardia. So today I want all of you to be thinking like you are doing lap in a Formula One race. That's all the game is all about. Let your neurons take all the pressure. Okay, so we started for the first one. Very good, guys. Atrial fibrillation and multifocal atrial tachycardia. And now I will focus on certain line diagrams which are like very classical. Like in this particular diagram, you can notice that I've shown systole and the pulse is rising very, very slowly. So because there's a slow rise as compared to a normal rise of the pulse, so you could pick up the slow rising pulse, which is also called as pulsus parvus retardus. We will be calling this as a anacrotic pulse. So done with the first one. Now I want you to focus on the speed breakers. Now I will, instead of saying percussion wave, tidal wave, I will just say speed breaker 1, 2, speed breaker 1, 2 like that. And then speed breaker once again. But then you will notice that a couple of speed breakers, like if I start with the last input that I have highlighted, here you can see that one peak of the speed breaker is in the systole part and the second one is in the diastole. This whole thing is systole. So because the pulse ka one part is coming in systole, the second one is coming in diastole. So this would be dicrotic pulse. That is the last line diagram that is shown. And now I will focus on what came in last time's paper. They gave a graph like this. One peak was bigger, the second one was relatively smaller. So if you're having two peaks present and they're unequal in size, this is the jerky pulse I was talking about. Imagine a speed breaker in the heart due to a free wall obstruction, due to septal hypertrophy. Like, when it comes to patients who are having hypertrophic cardiomyopathy, there is a lot of useless muscle in the heart. Though I will show you a postmortem specimen subsequently, just a quick 30-second look into, even I would say not even 30-second, 15-second look into septal hypertrophy, and then you can see free wall of the heart is also hypertrophied. So since I have shown like a lot of abnormality, banana shaped cavity, and you can see that the free wall of the heart itself is going to be causing trouble. The free wall hypertrophy is going to cause a trouble. So the answer for this is going to be hypertrophic cardiomyopathy. Yes, that is a banana shaped heart shown before you. This was a two-step question of your exam. He gave a pulse like this. He did not say this is a pulsar because he knows that you will kill the question immediately. That is hypertrophic cardiomyopathy, pulsus bisvarians. What he asked in the exam was that which heart valve is the one which could be involved in this condition. So in hypertrophic cardiomyopathy, it is an example of subvalvular aortic stenosis. So it was two-step question. You had to think about the fact that, okay, this is hypertrophic cardiomyopathy. Next is that there would be a subvalvular aortic stenosis that is present. So these are going to be the line diagrams which are going to be helpful for evaluation. Okay, guys. So once we are done with these representations that I've done here, we'll also talk about abnormalities of the JVP. So as far as the normal JVP value is concerned, you all know it is 5 to 8 centimeters of water. We use the anatomical landmark as angle of Lewis, and this would be checked in the internal jugular vein. But if somebody is very bulky, somebody very hefty person like President Trump, then we might be using external jugular vein as well. But preferably it is the internal jugular vein. Now in physiology, what they will do is they will mix you correlate the waves of the JVP with the ECG findings in a patient as well. If you can just draw this line diagram, if you can remember the peak of the R corresponding to like where the C would be starting, you are 50% done for the job, because if you get that orientation right, the remaining thing is totally visual. Like for example, the X, when it is happening, the ventricular systole is getting over. So it would be from R to the end of the T wave that the systole would be present in a patient. So sometimes they will ask you the ECG based from physiology, but if you can get 50%, if you get this orientation right, that peak of the R will be related to C, then the remaining things automatically fall into place, because he might say that what wave is going to be seen or what interval will be seen after it. So it will be the ST segment or it would be the T wave that is present in a patient. And obviously we have the normal waves in the JVP like the A, C, B, X, and then subsequently like we have is the X and the Y descent happening in a patient. At this moment, what I also want to say is that normally JVP will always be showing a fall on inspiration. If you and me take a deep breath, then the JVP will always fall. But if it is showing a paradoxical rise, that is a cause of concern. Now, what could be the causes responsible for this? The mnemonic for that is COPS restrict right heart. Well, COPS का काम ही यही होता है that they would be doing restriction. So I'm gonna talk about 3 conditions which are gonna be very, very classical asked in the paper. One is constrictive pericarditis, where there would be calcification outside the heart. This is a sequelae. Then by restriction, I mean restrictive cardiomyopathy, where they have a fibrosis in the heart. And then for right heart, it is obviously right heart failure. Now, whether he wants to write down inferior MI, whether he wants to write down cor pulmonale, that is his choice. But then C and then R, and usually the trick in the question, you very well know that C part will be written as cardiac tamponade deliberately. He will say all of the following are causes of Kussmaul sign, except then the answer is cardiac tamponade. I'm not writing it because that will come up in the discussion subsequently. Cardiac tamponade has a non-pulsatile. There you cannot pick up the rise of the JVP. Cardiac tamponade is the only medical condition where we read regarding the presentation of I would say non-pulsatile elevated JVP. I mean, if you like, just read the statement non-pulsatile elevated JVP, you know it's cardiac tamponade. So there would be 3 options like this, and one option would be that of cardiac tamponade in a patient. So C, constrictive pericarditis. R would be restrictive cardiomyopathy, and then would be right heart failure in a patient. These are the findings which have to be remembered for Kussmaul sign in a patient. Let me write down the logic. Kussmaul sign is seen due to calcification outside the heart. By socho heart ke aspas there's like a thick cement wall, so it will limit the filling of blood in the heart. There is no space available. Restrictive cardiomyopathy, the problem will be fibrosis. So again, there is like a limitation in the filling, and fail heart to बेचारा क्या ही काम करेगा. Again, the common thing what you would have seen in these patients is compliance. The compliance of the ventricles will be substantially reduced. Compliance का मतलब क्या होता है? Ability to distend, relax and receive the blood. You and me take a deep breath, our heart can relax, it can accommodate the blood. But in this condition, because there is like a inability to relax, that is why the column of blood will remain prominent in the jugular vein. That's why we get a Kussmaul sign in a patient. And now we come to the very favorite part of our exam. A wave is seen with atrial systole. Everybody knows there are 3 MCQs which you should be able to do under 1 minute. Large A waves, absent A waves, super large A waves. Yes, guys, quick answers here for condition that is having large A waves. This question that I'm discussing is not only asked in FMGE exam, but is a favorite on NEET PG examiner. NEET PG 22, 23, 24, फिर बोर हो गया उसे पूछना छोड़ दिया, और आपके एग्जाम में तो पूछ ही लेता है tricuspid stenosis, because there is a physical obstruction that is present. All obstructive lesions. अभी rational क्या करना है? I'll not draw line diagram. What I want you to remember is that any obstructive lesion of the right side of the heart, atria will have to apply more force to push blood in a forward direction. If you have a physical obstruction present, TS or PS in a patient, then the heart will have to the heart will have to generate more force to push blood in a forward direction. So very good. TS and PS are the best examples. Now comes the third entry. The third entry is not a physical obstruction, it is a pressure based obstruction in a patient. Pressure based obstruction would be pulmonary artery hypertension in a patient. So message for large A wave is TS, PS and pulmonary artery hypertension. The difference between the last point and the first two is that TS and PS are physical obstructions and pulmonary artery hypertension is a pressure based obstruction. Very good. Suman and everybody else were like spot on for the next one. Nadeem mentioned the definition also. चलो बाकी लोग भी कमेंट कर दो फटाफट से चैट बॉक्स में. What is the definition of pulmonary artery hypertension? Mean pressure more than how much is defined as pulmonary artery hypertension? That would be more than 20 millimeter of mercury. Normal is gonna be in the range of approximately like 15 millimeters of mercury. Very good, very good. Anand, Rajesh, Shashi, good. Now we will talk about absent A waves in a patient. That is for the commonest arrhythmia that we come across. The commonest arrhythmia overall in clinical practice is atrial fibrillation, whether hypertension patient, geriatric patient, cardiomyopathy. बोले ना cardiomyopathy patient में भी कौन सा arrhythmia होता है? Ventricular मत बोलना. It is atrial fibrillation which is the commonest arrhythmia across all age groups, including rheumatic heart disease with mitral stenosis. How will he write? How will the examiner write atrial fibrillation? He will give you an Indian scenario, rheumatic heart disease with mitral stenosis. Or how will the examiner write it in the MCQ? He will write the word alcohol-induced dilated cardiomyopathy. That means structural damage, and that structural damage can then trigger atrial fibrillation in the patient. So we are done for two. One is large and absent. Now we talk about super large A waves. Big pulsations on the neck called as frog sign. I posted a video on YouTube also regarding the frog sign component. I mean, like they show on a Discovery Channel or like a Nat Geo in the rainy season, the frogs will be croaking, so there would be pulsations at the neck of the frog. So those big pulsations would be present. And yeah, first word that you should say as a doctor for this is AV dissociation, atrioventricular dissociation. What it means is that atria and ventricles are contracting together. If atria and ventricle will contract together, the power of the two will be added. And that is why you get a super large A wave. I will say that again. Normally, A wave is due to only the contraction of the atria. But if atria and ventricle both are gonna be contracting together, then I will say AV dissociation, super large A wave in a patient. Now, the condition that will be associated with this from the tachycardia component or tachyarrhythmia component is VTAC. Very rightly put up by everybody. And the Brady component of this would be complete heart block in a patient. So both of these conditions, ECG, will be discussed in the subsequent part. But at the moment, you need to remember, every time the word AV dissociation comes, it will be ventricular tachycardia / complete heart block. The point to be understood is AV dissociation means lack of coordination between the upper chamber and the lower chambers of the heart. Yeah, PSVT can be another reason, but the point is there has to be either a tachy or there has to be a bradyarrhythmia. The alternative name for complete heart block is Stokes-Adams syndrome. And now we are good to go for the next question, that is absent X-descent. Now today, absent X-descent is like a finding which is normally X is negative now, but in this condition, this would be seen with yes. You are doing the right job by like commenting on the points which are present here. Yes, it would be tricuspid regurgitation. So जानबूझ के change कर दिया ना, TS पे उसने बोला large A wave, now would be tricuspid regurgitation in a patient. That would be absent X descent in a patient. What I will also do is the line diagram of this, which can be put up to you. This is the normal wave in the JVP. That is the ACV and then the X and the Y descent respectively. He can give you a line diagram like this where the A will be the same, the C will be same, and then there will be no X. He will show dotted like this. और यहीं से कॉलम को उठा देगा, यहीं से कॉलम को उठा देगा. Like they may be giving you this particular finding that I've shown, where you can see that the upswing is happening even much more earlier. So where I put the horizontal arrow, we will say the CV wave, and where I put the star mark here, this is what is called as a steep Y descent. Very good, Nadeem, you were able to pick it up immediately. The star mark is the steep Y descent. So actually, if you look at the analysis, tricuspid regurgitation is answer to 3 questions right in front of you. Tricuspid regurgitation He's answered 3 questions: CV wave, steep Y descent, and a absent X descent in a patient. Those are like the 3 standard issues that should be remembered by you for TR in a patient, tricuspid regurgitation. What I will also do is make a 15-second line diagram showing the same. This 15-second line diagram will help you revise why all this is happening at the moment, because in my opinion, instead of mnemonics, because mnemonics तो याद लास्ट में याद नहीं रहते, इट इज जस्ट अगर आप ये लाइन डायग्राम देख लोगे ना तो यू विल रियलाइज द फैक्ट, और मैं ऑलमोस्ट 15 सेकंड डाउन हो चुका हूँ, एंड यू विल रियलाइज दैट व्हाई एम आई सेइंग दैट एक्स विल बी डिसअपीयरिंग, यू नो, ऑलमोस्ट लाइक हिटिंग 20 सेकंड, और अभी आप देखोगे कि सीधा एक्स मैं गायब करने वाला हूँ। क्यों? क्योंकि एक्स तो डाउनवर्ड डिस्प्लेसमेंट होती है, एक्स इज अ डाउनवर्ड डिस्प्लेसमेंट। नाउ लुक एट माई एरोस, tricuspid regurgitation. Now no MBBS, no MBBS, only vectors. Vectors going up, vectors going down, cancel each other. If they cancel each other, you get an absent X descent in a patient. So if you look at this line diagram here, tricuspid regurgitation is the spot on fact for where these possibilities would be present. So I think I had a very good response with respect to this particular table. अभी तक तो मतलब पूरा अच्छे से याद कर लिया आप लोगों ने, so I'm really happy for that. And now we come to the one which is the most frequently asked one also. Okay, let's look at what you guys have to comment for absent Y descent in a patient. Absent Y descent, this is the most neglected part. This is the one which is always gonna be asked to you, cardiac tamponade. Yes, absent Y descent, filling नहीं हो पाएगा ना in a case of cardiac tamponade. So we will be having is a absent Y descent, and to make it sound sophisticated in the paper, उसने क्या किया? He said steep X and absent Y. Now some guys they got, you know, कई तो निमोनिक विमोनिक के चक्कर में पड़ गए और कई कंफ्यूज हो गए कि सर आपने एब्सेंट वाई बताया था। तो मैंने बार बार बोला है भाई, यू नीड टू कट द नॉइज एंड अंडरस्टैंड व्हाट इज रेलेवेंट. Relevant is absent Y descent. MCQ will be full of noise and you need to cut down the noise. The answer will still remain the same. Steep X and absent Y is a feature that is seen in patients of cardiac tamponade. This is a medical condition in which the heart will be squeezed or crushed by a lot of fluid or blood or malignant pleural effusion, malignant pericardial effusion in a patient. Yep, now is the change. Now is the change. Steep X and steep Y, यहाँ पे ना दोनों दोनों स्टीप बोल रहा है, दोनों दोनों स्टीप बोल रहा है। अगर वो एब्सेंट Y बोलेगा तो टैम्पनेड हो गया, पर अगर वो दोनों दोनों को बोलता है steep X and steep Y, then you will straight away say constrictive pericarditis. And most of the time, to assist you, in my opinion, what they have done is they've either given an X-ray or sometimes they've given a CT chest. If I zoom into the CT chest, it is impossible. Like I had one guy, he said, "Sir, मुझे तो ये सब कुछ याद ही नहीं था कि what is steep X and what is like steep Y. All I remembered was that there was calcification around the heart. I answered it as constrictive pericarditis. Is my answer correct?" I said, "Very good." I mean, question has to go correct. Whether you go solve it on the basis of a CT scan, like most of you have identified the thick zone. Heart के आसपास तो there is no calcification ना. So the moment you pick up that calcification outside the heart, you know that okay, fine, this would be constrictive pericarditis in a patient. So constrictive pericarditis is always a sequelae, and most of the time the cause of this would be tuberculosis, or if it is not TB, then he might mention regarding pyopericardium. Pyopericardium would mean that the pus would be coming in the pericardial space of the patient, and where the pus will be coming from, it will be coming from the pleural space. Like this kahani kya thi? The story will be this patient initially had a pneumonia. Pneumonia antibiotics were not started, so the patient ended up with empyema. Empyema means pus in the pleural cavity. So pus in the pleural cavity, because pleural cavity and cardiac cavities are, and the cardiac pericardial space are close together. So empyema could result in development of pyopericardium. Though you will give antibiotics and you might even drain the pus, but the sequelae or the complication of this is constrictive pericarditis. So it is not a direct result, but it is TB, pyopericardium. Or like one more risk factor I can mention is he might try to create a story that it is a female, she had undergone a modified radical mastectomy for stage 3 breast cancer, and then she was given radiation also. Now if radiation will be given, then the good thing is that we will destroy the cancer cells, but it can damage the heart as well, and therefore constrictive pericarditis can be a sequelae developing in a patient. Like the question will say, lady with breast cancer, MRM done. It could either be a recurrence of breast cancer. If not a recurrence of breast cancer, it could be like the initial presentation only. And radiation is obviously going to kill the cancer cells, but the bad news is it could cause calcification in and around the heart of the patient. So this was a very welcome slide. And for cardiac tamponade, I'll just draw a quick diagram here. This diagram helps you remember why there is a impaired filling. You can draw line diagram like this where there's a lot of fluid outside the heart, then show these big veins. And you can now see that if I will be showing water outside the heart, if I'm going to be showing by water in literal sense, I mean it is inflammatory fluid. This is due to tuberculosis. This could be due to malignancy. It will squeeze. It will crush the heart from outside. So you can draw some arrows to say intrapericardial space pressure is rising. I want everybody to comment in the chat box what is the echocardiographic finding of cardiac tamponade. Because of this pressure now, the filling of blood will be less, like oxygenated blood on the left side and deoxygenated blood on the right side will not be able to enter. So that's why there's a absent Y descent. Can you quickly comment in the chat box with respect to what will be the echocardiographic finding in cardiac tamponade? He will always use the word yes. Echo beta, echo finding, diastolic collapse. ECG finding is low voltage ECG. ECG finding is a low voltage ECG. Diastolic collapse beta, money bag appearance is a chest X-ray finding. आप वर्ड्स को फॉलो करो. Echocardiographic finding will be diastolic collapse of the ventricles of the patient. ECG finding सबने सही बोला. Low voltage ECG, electrical alternates. Everybody got it spot on. If I say what is the chest X-ray finding in the patient, the chest X-ray is a money bag appearance. Everybody got it spot on. I slightly modified that. Diastolic collapse of ventricle. मतलब क्या? Impaired filling. When I say the word diastolic collapse, it means that the intrapericardial pressure will exceed the left ventricular and diastolic pressure. Imagine in your pericardial space there is a lot of fluid present that's squeezing the heart from outside. That pressure will cause a diastolic collapse of ventricles, due to which the pressure in the ventricles will rise. Imagine if your ventricular pressure will rise, then blood cannot come from atria to ventricle. इतना तो मानते हो, atrial pressure will be more than the ventricles during the phase of diastole. If the ventricular pressure will rise, the filling part will be significantly compromised in the patient. Yeah, but a pericardial shudder is a auscultatory finding that comes in constrictive pericarditis. अभी करेंगे, उसकी भी बात करेंगे, right? But at this moment, the word that I expect you guys to understand is ECG finding, low voltage ECG. Chest X-ray finding, water bottle or money bag heart. But if I change the language and say what is the echo finding, then it is a diastolic collapse of the ventricle. Yeah, you can have an atrial collapse also. Obviously, initially atrial collapse, then ventricular collapse would be occurring. So at this moment, we are sorted for these tricky, so-called tricky questions. They're not at all tricky. If you just get the language right, you will be in a position to evaluate these questions relatively better. So no need of mnemonics. Logic is always, rationale is always supreme. Okay, so now we test your knowledge on pericardial diseases. Comment on the chat box with respect to, yeah, Karthik, I'll solve that for you. When is the money bag appearance gonna come? Right in front of you. What is the ECG finding of acute pericarditis? While you are busy answering that, I will be writing auscultatory finding. Auscultatory finding of acute pericarditis will be pericardial friction rub, because there is a serofibrinous fluid. There is a serofibrinous fluid which is present outside the heart. So there is like a inflammation between the two layers of the heart. So pericardial friction rub is due to inflammatory exudate present in the outermost layer of the heart. Yeah, they gave a ECG last time in the paper. They said patient has come with chest pain after a URTI. The ECG showed ST elevation in all the waves. The highlight of pericarditis is ST elevation hota hai. But the ST elevation is different from that of myocardial infarction. It will be concave in upward direction. It will be concave in upward direction. It will be present in all the leads of the heart. Like I can say that pericarditis is 360 degree around the heart, 360 degree around the heart. But when it comes to MI, the findings are found in only some leads only, overlying leads. Like for example, if I say MI, then anterable MI is gonna be V2, V3, V4, inferior MI is 2, 3, VF. Inferior MI तो इस बार यार INI-CET में पूछ लिया अभी last week में ना. Like people were saying very conceptual. Inferior MI तो यार favorite है FMGE examiner का. उसने कहा चलो अब INI-CET वालों से पूछते हैं. So some guys do a blank, but yeah, most guys were able to get it correct also. That is, all the leads will be showing except lead number AVR. Except lead number AVR, because AVR वाला जो lead होता है उसमें you would be finding that the P wave and the T wave will be negative. So AVR जो lead होता है तो वो हार्ट को उल्टा पड़ता है ना, उसमें P wave और T wave नेगेटिव आती है, तो उसमें आपको ST elevation नहीं मिलेगा, उसमें आपको ST depression मिल जाएगा. Like in lead wave, yeah, we'll also get couple of other findings in this condition like a PR segment depression. So I had like good inputs for the ECG finding of this condition. How the question was asked in last time's FMG exam was, he said कि एक patient को पहले खांसी जुकाम हुआ. You can just remember जैसे COVID के time पे था. At COVID time, lot of people were having pneumonia and then they were having chest pain. That chest pain was not because of pneumonia. That chest pain that was occurring was because of COVID-19 pericarditis. So he gave a similar kind of a history. It could be influenza, it could be Coxsackie. But if post URTI, there is a person having chest pain with pericardial friction rub, then this was the data that would be given to you along with ST elevation. The X-ray findings in this particular condition will be normal because there is no fluid outside the heart. There is no calcification around the heart. So the cardiothoracic ratio in this condition would be normal. But yeah, sometimes they can ask you a autoimmune pericarditis that is seen after MI. This is a late complication of myocardial infarction, and you guys have to comment with respect to what is the drug for treatment of Dressler syndrome. It is a autoimmune pericarditis. The examiner himself will highlight the word autoimmunity, and yes, you have to avoid the trap. Autoimmunity, if it is autoimmune given in a question, then for autoimmune pericarditis, you will be answering as aspirin. Yeps, we will not be giving steroids. The examiner wants me to give steroids. I will not follow the trap. It is aspirin 650 milligram 3 times a day. Forget the dose. The point is we want to avoid steroids. Post MI, there's a scar formation. No? First, we have collagen formation, right? Type 1, type 3 collagen. Those are the types of collagen that will be giving strength. So steroids interfere with collagen formation, and as a result of this, the scar formation will be poor and it can predispose to left ventricular aneurysm. That is the reason why in this particular patient, it is like aspirin that should be used in the patient and not steroids. Now we come to the right hand side, pericardial effusion. For pericardial effusion, now the rub will disappear. Same patient, due to viral URI, due to TB, now the pericardial friction rub will disappear. And the ECG of this patient, because there is fluid outside, will now start having low voltage ECG. So a lot of you were saying low voltage ECG, that is a ECG finding of pericardial effusion in a patient. The heart is dancing in the bag of fluid. So in some questions, to make it sound a little sophisticated, because he knows that young chaps like you are smart boys and girls, you will pick up low voltage ECG. So उसने क्या करा? He changed the language. He said electrical alternance. The heart is dancing in the bag of fluid. The heart is dancing in the bag of fluid. So he changed that data to electrical alternance. Now when you will do X-ray in this patient, the X-ray will be revealing money bag appearance. If you are money minded, money bag appearance. If you say that, by I am a monk, or like I have given up for everything, I just need basics of life. Basic is hawa pani, so pani wala heart, that is water bottle heart. So depending on whether a doctor is a money minded person or whether he's a monk and he says I am free from worldly sins, the word would be money bag or water bottle heart. Both of them basically mean the same. The common reasons why in India patient can develop a pericardial effusion is going to be either TB, or it could be one of the most aggressive lung cancers, that is oat cell cancer in a patient. Can you tell me histopathology finding of oat cell cancer, please? Characteristic feature that is found only in oat cell cancer in the slide. Histopath finding in oat cell cancer. One is obviously that nuclear pleomorphism, crushed nuclei. I mean, understand, oat cell का मतलब यही होता है ना, ये जैसे न्यूक्लियस जैसे ओट का दाना होता है ना वैसे. So there would be crushed nuclei that would be present. The characteristic manifestation, yeah, smoking history will be there. Histopath I'm asking, beta, histopath finding. Yeah, oat cell cancer or small cell cancer will be having crushed nuclei. Obviously cells तो छोटे ही होते हैं, but how do you pick up? Like देख के थोड़ी ना पता चल रहा छोटे हैं या नहीं है. Yep, the one of the histopath findings in this condition is called as azopardy phenomenon. And what is azopardy? Azopardy phenomenon would be the blood vessels wall will appear blue. Normally तो blood vessel की जो wall होती है वो pink होती है ना. But in this condition what will happen is कि जो blood vessel की wall है वो उसमें basophilic पूरा का पूरा मतलब cancer cells are slamming into it. So even the wall of the blood vessel will be having intensely blue appearance because of the cancer cells infiltrating into this. So the finding that you get in the patient is crushed nuclei. That is why oat का जैसे oats नहीं खाते यार, oats का जैसे दाना होगा वैसे coffee bean मत समझना, coffee bean तो चौड़ा होता है ना. It is the crushed nuclei and azopardy phenomenon that would be present for oat cell cancer. जैसे squamous cell में keratin pulse देखते हो वैसे you can give a slide for this, no? That the slide is what you need to analyze. So it's the azopardy phenomenon. What you mean by azopardy phenomenon is basophilic appearance of blood vessels. Normally the blood vessels in anywhere would be seen like pink only in a hematoxylin eosin, but here they'll be appearing blue. That salt and pepper beta is a feature that you will be seeing with respect to carcinoid tumor. है ना. Salt and pepper is a feature that is more in favor of carcinoma tumor and not in favor of root cell cancer. That's one of the common mistakes that people do. That salt and pepper appearance, I repeat again, is a characteristic feature of a endobronchial mass. That endobronchial को भी लोग कैंसर सोच के चल रहे हैं. ठीक है, ट्यूमर है मैं मानता हूं, बट इट इज प्रोड्यूसिंग 5-HT derivatives, man. That is going to be carcinoma tumor in a patient. So don't get biased there. And yep, we are sorted for बेटा. That is IHC ना. सैनेप्टोफाइसिन और ये सारी चीजें तो इम्यूनोहिस्टोकेमिकल होती है. मैंने तो सिर्फ आपसे पूछा था हिस्टोपैथ में फाइंडिंग क्या मिलेगी. तो अगर तो आप स्पेशल स्टेन लगा रहे हो एंड अ रिच पैथोलॉजिस्ट हैविंग ऑल द फेक facility of IHC markers working in a very fancy lab, then obviously that IHC markers will turn positive. Yeah, oat cell cancer and small cell cancer is basically the same only. Okay, quickly guys, we are sorted for this. Quick answers please. Which is the commonest lung cancer, by the way? Overall most common lung cancer is? No, we will not answer pericardiocentesis in this case, because most of the time evidence of cancer and evidence of TB will be there on CT test also. So we can start the treatment without doing a pericardiocentesis. Yeah, overall the most common lung cancer would be METs, but if I change the language into, very good, it is first answer is metastasis only. And then if I change it to primary lung cancer, then most common primary lung cancer would be adenocarcinoma, where you will be able to see the glands. Quick comments in the chat box. Adenocarcinoma of the lung, what is the reason for development of this lung cancer, which if I say anything more, the answer will become obvious. Like this lady is saying, I don't smoke, my brother does not smoke, my papa does not smoke, I've never been exposed to passive smoking. Still this young lady is having development of lung cancer. So what is the reason for development of adenocarcinoma? This lady is crying in front of you. She says, doctor, like, why me? Like, why this curse on me? And most of the time this would be like a non-smoker female, maybe 35-40 years of age, and she's saying, sir, mujhe aisa kyun ho gaya? No beta, first answer is EGFR1. No man, lung cancers that begin with alphabet S are related to smoking. This is a cancer that is seen in non-smoker. This is a cancer which is seen more commonly in non-smoker. It is a peripheral lung cancer. So the question is like, why did it occur? Then your answer is EGFR1 mutation. KRAS भी होता है, हाँ जी, but is that most common one? No ना, it is EGFR1. बहुत सारे होते हैं, KRAS भी होता है, ALK भी होता है. If you miss this question, please check out your pathology notes. This is not the kind of a question that should go wrong. It is a sporadic mutation that would be occurring in a patient. Sir, most common primary lung cancer is adenocarcinoma. It is EGFR. The causes of that are KRAS and ALK also, but they will ask you the one which is most common. It is a sporadic mutation that is developing in this patient. If you check out the genes if you check out the genetic mutations responsible, no, for then it is EGFR1 that would be responsible. But BRCA1 BRCA1 जो होता है वो ब्रेस्ट कैंसर के लिए होता है. BRCA1 is for breast cancer. चलो एक और क्वेश्चन करते हैं. बड़ा वियर्ड से इनपुट्स आ रहे हैं. सो आई विल मेक यू डू या चलो अभी हम नैप्सिन 1 की बात नहीं कर रहे हैं. What is the most common cause of breast cancer? This lady came to a hospital. Why I'm discussing is because breast cancer can ultimately metastasize to heart, and there can be a pericardial effusion, cardiac tamponade in a patient. So what is the TTF1, napsin, they're all related to the IHC part. I did not ask you the IHC part, beta. I asked you regarding what is the cause. Like she's asking me, क्यों मुझे हो गया? So it is the genetic mutation that is responsible. Okay, what is the most common cause of breast cancer? P53. Okay, now I know you will kill the options. B or BRCA1, BRCA2. Yes, HER2 new. Which is the most common one? Which is responsible for development of breast cancer? Most common cause of breast cancer. And most patients with breast cancer can then move on to ending up with a pericardial effusion and can end up with a cardiac tamponade in the patient also. Okay, I am getting all kind of answers here. Sir, the most common cause of breast cancer is only sporadic. If you're answering BRCA1, BRCA2, that is for familial. I mean, you're not supposed to. मैंने क्या ऐसा बोला क्या like her sister was having a cancer or his mama was having a cancer, her nani ji was having a cancer? Not like that. Did I ever say? I never said familial. Mostly it is a sporadic mutation, that would be a P53 mutation. The overall number one cause why you can have breast cancer in a patient is P53 mutation. And for all cancers, if you're getting this wrong, suggestion to all of you is, though I know you love pathology and you've done pathology well, write down the name of all tumors and first write down the mutation for it. Then write the number one mutation for it, then write down the number one IHC marker for it, and you are done for it. Then you will not fall in the trap of salt and pepper chromatin random answers coming up there. Just do this activity and I'll tell you that you will be even much more comfortable in doing medicine questions, because ultimately, like, a lot of these cancers can move on to the heart and can result in a pericardial effusion and can result in development of a cardiac tamponade in the patient also. Very good, very good. Shashi, you have a point. Mohammed, you have like TP53 or P53 mutation as they say, because mostly जो होता है यार वो तो sporadic, आपने इतना देखो, आई से लॉट्स ऑफ टाइम आपने बहुत ज़्यादा केस नहीं देखे होंगे, बट सुनते तो हो यार, देखते तो इंस्टाग्राम पे तो आजकल सारे लोग पेशेंट्स के बारे में डालते रहते हैं. सो इट्स मोस्टली लाइक अ स्पोराडिक ब्रेस्ट कैंसर दैट इज प्रेजेंट. द रीजन आई वेंट इनटू दिस डिस्कशन, दो इट इज नॉट माय डोमेन, इज जस्ट टू एक्सप्लेन टू यू दैट ब्रेस्ट कैंसर कैन मेटास्टाइज टू द हार्ट. एंड सो आई मीन दैट क्वेश्चन विल बिगिन लाइक दिस: breast cancer lady comes with shortness of breath, and then he will say ECG shows a low voltage ECG. Chest X-ray shows a water bottle heart. So you're thinking in terms of pericardial effusion of the malignant nature in this patient. And yep, once we are sorted for this, we will now talk about the elder brother of pericardial effusion, that is cardiac tamponade. Cardiac tamponade question is super easy if we will mention the word muffled heart sounds. But unfortunately, I mean, I wish that in your exam, he begins the question by saying muffled heart sounds in a patient. And I'll say like this, that when I used to teach students prior to 2020, I never used to get into all the technicals of tamponade. I used to simply ask them to cram the word muffled heart sound and tamponade is sorted. But now obviously they don't ask questions like that. So he will begin by saying pulsus paradoxus. And pulsus paradoxus is something that if you are noting down, I want you to note it down across both of them. It is more common with tamponade. It is seen in tamponade. It may be seen. The word is may. So I'll just write that chota sa hai कि it may be seen in patients of constrictive pericarditis. Because it may be seen, therefore I cannot use pulsus paradoxus as a discriminatory point in the question, because it can be seen in both of them. So what you will do in the question is straight away focus on the JVP character, because the JVP character will always be given. Here he will always say, and this is the keyword, this is where a lot of questions revolve around, non-pulsatile elevated JVP is a feature that you see with respect to cardiac tamponade. But when it comes to constrictive pericarditis in a patient, you would be saying को small sign. So small sign is the rise of the JVP. इस पे the query is, sir, will you not get a को small sign in tamponade? So my point is कि भाई pressure तो बढ़ जाएगा, but will you be able to see the pulsations? No. Normally JVP is always pulsatile. Pulsatile, को small sign, what it means is pulsatile elevated JVP that will rise further on inspiration. It's a pulsatile elevated JVP, rises further on inspiration. Non-pulsatile is a feature that is seen with cardiac tamponade in a patient, and then is the JVP waves. In both of them, I know that आप बोलोगे सर ये तो हमें आता है, तो लिख लो, प्रैक्टिस कर लो एक बारी. स्टीप एक्स दोनों में होता है. स्टीप एक्स दोनों में लिखा होता है. But in tamponade, it will obviously be absent Y, and this would be a steep Y descent in a patient. Don't get into at the moment mnemonics. Just get the practice here in your mind, because when you will read the 3-liner, 4-liner question, then mnemonic will not click in. Then the data will click in. If ever in doubt, use blood pressure. If he says hemodynamic instability, in American books they write crushing patient. In our books, they say hemodynamic instability, then it is tamponade. For patients who are having constrictive pericarditis, well, I can say the blood pressure of the patient will be normal or will be slightly less, but at least it will never be unrecordable in the patient. And then I can say low voltage ECG to dono mein milta. Just like I said, pulsus paradoxus is not a discriminatory factor for me in the question. Low voltage ECG also in both of them. Obviously, the reason is different. In tamponade, the reason for low voltage ECG is fluid. And for constrictive pericarditis, the reason for low voltage ECG is calcification. So once you get that in your mind, you know that you cannot use low voltage ECG as a discriminatory factor. So what will you use for your discriminatory will be chest X-ray finding. That chest X-ray finding or tamponade will always be saying cardiothoracic ratio is increased. But I really wish that they in the question mentioned egg in a cup appearance. No, अगर वो मुझे egg in a cup दे दे तो फिर तो मेरे लिए सुपर इजी हो जाए. अब इतने क्लासिकल टर्म्स तो कभी लिखे ही नहीं होते ना. So what will you rely on? You will rely on the cardiothoracic ratio, because cardiothoracic ratio will be normal if there is a calcification, but cardiothoracic ratio will be increased if there is a cardiac tamponade present in the case. And then comes the issue of treatment. Obviously, if it is going to be a patient who's having cardiac tamponade, then we would like to go for pericardiocentesis. But a word of caution here, I'm putting a star mark here to say that if the question is especially on the topic of hemopericardium, he will say car crash victim not using a seat belt and there is a hemopericardium in a patient, then in hemopericardium there is no point of doing pericardiocentesis in a person, because I can take out whole of the blood of the patient. So if we will say hemopericardium and what is to be done, your answer straightforward is emergency thoracotomy. I am talking about only medical reasons. Like suppose there is a lung cancer that is squeezing, or there is a TB which is crushing on the heart. I would like to tubercular pericardial effusion crushing on the heart, to ease off the pressure, we can do a pericardiocentesis. But if it comes to hemopericardium, lots of these questions that come in the paper will be surgery oriented, in a sense that they would be blood present. So if it is hemopericardium, then the answer will be that we will send the patient over for emergency thoracotomy in the patient. And for the right hand side, obviously, like the comments were spot on and were correct for this one, that when it comes to a person who is having like pericardial person who's having this calcification outside the heart, I will go for pericardial stripping. We'll refer to obviously CTVS, cardiothoracic vascular surgeons. They are the real gods. They are the real demigods, I would say. Right? Though nowadays people don't want to take up CTVS because interventional cardiology has taken over, but then they operate on a beating heart, and they are the real demigods, I would say, that is unfortunately not taken. That's a branch seats that go vacant nowadays. Yep, so you are right. Pericardial stripping would be done in this patient. Unstable patient, should we directly do thoracotomy? Yes, Amia, perfectly spot on. Patient is hemodynamically unstable, I will straight away take up the patient for emergency thoracotomy. There is no other way. Earlier, they have done clinical trials on the same. Your doubt is very valid. All doctors have this doubt. First, I should take out the blood, stabilize the patient. He says it's a waste of time. Why a waste of time? You will take out the blood, more will come. Na? There's a laceration on the cardiac muscle. There could be laceration in the coronary artery. The blood is coming. If there's an arterial bleed happening, you remove that blood, more blood will come in the pericardial space. You can't remove all the 5 liters of the blood in a patient. So your point is well valid. He will deliberately create that situation of hemodynamic instability. Good question, Dr. Amia. And in spite of the hemodynamic instability, I am going to say, okay, not a problem. We can do an emergency thoracotomy in the patient. So the point is, if it's TB, lung cancer kind of a scenario, no need of thoracotomy. Obviously, in TB, you're not going to open up the chest, man. That's going to cause dissemination of the disease everywhere, right? So, I mean, all of you are smart enough not to fall in the trap of the examiner. But if he says hemodynamic with crashing with hemopericardium, yep, answer is emergency thoracotomy. Okay, what investigation? Echocardiography, man. Anything in the cardiac evaluation is an echocardiography. In fact, when patient came to me in a car crash, I don't even know I might be doing a fast. In a fast, I can put a probe in the ziphisternal area, and I can put the probe upwards, and I can still see the blood or the fluid around the heart of the patient. So ideally, if he says, how do you identify any pericardial diseases? For any of the pericardial diseases or any valvular diseases, we should be doing is a urgent bedside echocardiography. Now, suppose you say to me, in the emergency room, there is no echocardiography machine. So suppose patient came in the emergency room and I'm suspecting that the guy is having a query cardiac tamponade. I can do ultrasound in the patient, because obviously, like in the ER, there is no facility of any echocardiographic machine most of the time. So it is an ultrasound that would be done in a patient. Okay, so this was a quick comparison between the two. I just elaborated a little more because I wanted you to be very, very thorough with this slide. And now we will focus on the aspect of murmurs, which they again love to ask in your exam. Ejection systolic murmurs, pan-systolic murmurs. The mnemonic is PASS. So I want you to comment in the chat box quickly with respect to the murmurs that are present for ejection systolic. The PASS mnemonic would stand for two conditions, that is pulmonic stenosis, and second would be aortic stenosis. Though I've given you hints for even the aortic stenosis earlier, no, we discussed that pulse finding, and a carotid pulse will be given, carotid thrill will be given in the question, and he still wants to trouble me with the murmur. I will say ejection systolic murmur in a patient. Yes, for pulmonic stenosis, usually what he will write is Noonan syndrome. Usually For patients who are having pulmonic stenosis, he might write the word Noonan syndrome in a patient. And for aortic stenosis, he may deliberately mention the word like senile calcification, like Arnold Schwarzenegger. He recently underwent TAVI, that is transcatheter aortic valve implantation. The guy who played Terminator, I mean, though is my generation hero, but Mr. World and the best bodybuilder in the world, Arnold Schwarzenegger, underwent, and even you guys would have seen the Terminator movie, if not see Terminator 1, where he drives that Harley Davidson off that ramp, and you see that like he'll drive a Harley Davidson off the ramp with a gun in one hand, and you'll, especially for an action movie buff, you will see, and immediately your pupils will dilate and you get hooked on to the kind of stunts that guy has done. Exactly. Aortic stenosis is seen in infants and is also seen in old people. And then another one in is this is hypertrophic cardiomyopathy. Nadeem, you have a very good input. I'll rather ask it to everybody since you said that. What is the most common valvular lesion? What is the overall most common valvular lesion in infants? The chat is open. Those who have answered, please remain silent. Yeah, absolutely. I mean, the slang words can have a lot of meaning, right? Disrespectful as well. Most common valvular lesion in infants. Exactly. That would be valvular aortic stenosis in a patient. Yep. The commonest valvular lesion in infants is valvular aortic stenosis. And now what I will do is I will show how the line diagram of this will be given to you. You can draw this once with me. Just show turbulence. Just show turbulence in systole and increase the severity of the turbulence, and you will notice that you'll get a murmur that would be called as a ejection systolic murmur. This murmur is also called as ejection. You can enhance in the middle. You can also call it a ejection systolic murmur. That would be the description for the first one that I have discussed. Now comes pansystolic murmur. For the pansystolic one, the representation in the paper was given like this. The intensity will remain uniform all through the duration of systole. The intensity will remain uniform all through the duration of systole. So we call it a pansystolic murmur. The mnemonic for this is MTR Vada. MTR is a brand, especially if you love dosa or if you eat idli and you don't get good ones in North India. And then if you are into North and you want to eat idli and dosa, then this is one brand that will provide you with that ready-made material. Obviously, you can get all those liquid formulations that are available. Most of them are contaminated ones. So this is one brand I'm telling you. If you're craving idli or dosa and in your hostel room, you can use this to your advantage. And no, this is not a paid promotion. So MTR is mitral and tricuspid regurgitation, and the VADA will be standing it for VSD, that is ventricular septal defect in a patient. So MTR VADA is a mnemonic for remembering this. One of the classical, I would say, congenital heart diseases, ventricular septal defect. Quick comments with respect to which is the commonest variety of ventricular septal defect. This itself was a question of your exam, the PYQ. I'm writing options here before you: perimembranous variety, muscular variety, then you have the mixed variety, then you have the supracrystal variety. So which is the most common variety that we encounter? Yes, perimembranous is the found in 80% of the cases. Like in the paper, it was not written as only VSD, it was perimembranous VSD, muscular VSD, and supracrystal variety of VSD. Most guys have got it perfectly spot on. The supracrystal variety CRIASTL is seen with valvular aortic regurgitation as well. So we have sorted for two murmurs here, for pansystolic and for ejection systolic murmurs. The mnemonic are PAS and MTR VADA. And now we come to those classical names, GAP and CAM, for the diastolic murmurs. At the moment, two names that should never ever go wrong. One old MCQ of your FMGE exam was Graham-Steele murmur. I'll write down the data in few seconds from now. Graham-Steele, that is the G. And the second I want you to never ever forget in your life is Austin-Flint murmur. So what I will do at the moment is, for the CAM and the GAP, I will write down the data. Graham-Steele murmur. Whenever you read the word Graham-Steele murmur, what you should always remember is that this is due to severe pulmonary artery hypertension. In contrast, Austin-Flint murmur is seen with severe aortic regurgitation. You need to remember a bit of, I would say, verbal cues at the moment. Austin-Flint begins with A, and that would be for the aortic regurgitation. That's gonna be with respect to the aortic regurgitation variety, right? That is Austin Flint and aortic regurgitation. Pretty straightforward, guys. Yes, Rajesh, you are spot on. Nadeem, you put in the perfect point, and Shashi, okay, mild PR. Okay, so maybe you are saying for the subsequent data that I'll be writing. So you preempted my words. But at the moment, what I want you guys to remember is that severe is the prefix, both for Graham Steele and for Austin Flint. Why are they asking you that? Is because it's related to a severe condition. Now, Austin Flint, if you remember with A and A, you are sorted with the fact that if one is sorted, the other one you can work out now is a feature of severe pulmonary artery hypertension. Now, all ears, pay attention, all of you. The word is, that's what they played the game with. It is severe pulmonary artery hypertension causing mild variety of pulmonic regurgitation, thoda sa blood leaking. So you will be having is a early diastolic murmur. Whereas in severe aortic regurgitation, lots of blood leaking. So you would have a long duration murmur that would be called as a mid diastolic murmur in a patient. So the first thing I wanted to remember is Graham Steele murmur में उसने combination बना दी. What were the combinations given? Severe PH, severe PR. Mild PH, mild PR. Severe, mild, severe, mild, severe. You can understand anybody can, lose patience while doing it. So you need to spend 15 seconds with me. Say that with me. I know you're very far away. You are in a distant city. I'm in a distant city. Say with me. Graham Steele murmur is due to severe pulmonary artery hypertension leading to mild pulmonic regurgitation. Whereas Austin Flint murmur is due to severe aortic regurgitation. Guys, beta, abhi Shams, you were perfectly spot on, right? I'm just trying to emphasize क्योंकि वो बाकी जो होगा ना, जो भी आप बोल रहे हो, all of you are perfectly spot on. That will be the filler options in the question. What he will ask you here is the data that I'm trying to teach you at the moment. For the gap mnemonic, आपको पूरा नहीं याद रखना है, आपको ग्राहम स्टील याद करना है. वो तो obviously because I have to finish a mnemonic and because I am a teacher, I can't jump the topics and say कि बस इतना कर लो हो जाएगा. Right? My job is to tell you the whole data. So it would be a mild aortic regurgitation, little bit of blood coming in, very short duration murmur. Mild variety of pulmonic regurgitation. So the point to be understood is वो पूछ क्या रहा है? Classical names पूछ रहा है. The classical name, जब भी पढ़ोगे, classical names are the ones which are basically to be focused upon. Now, once you've done that, very good, guys. I think most guys have, or they have given the correct answers for this one. Okay, good. So now I will come to the remaining cap one, please. Okay. Yes, the cam mnemonic. Now coming to the right hand side of the discussion, that is gonna be C for Caricom's murmur. Caricom's murmur is a characteristic murmur of rheumatic valvulitis. I will be like drawing the line diagram for the same as well. But यहाँ पे याद करना है C, then A, and then M. The M would be the murmur of mitral stenosis. So step one. Now step one is already done. That is the severe correlations I said. Step two is all except MCQs. Gap and cam. एक practice करो मेरे साथ right now, right here. Cam is gonna be Caricom's, Austin Flint murmur, and mitral stenosis, the commonest valvular lesion in adult population with rheumatic heart disease. If I say the word rheumatic heart disease, then it is mitral stenosis. But if he says the word rheumatic fever and the murmur associated, then what will you say? Caricom's murmur. I hope you are picking up the difference there. Are you picking up the difference there, guys? He will say the word rheumatic and then he will say valvulitis. If he says the word rheumatic valvulitis, the murmur associated, then it is Caricom's murmur. And if he says the word mitral stenosis, then obviously like rheumatic heart disease, then because rheumatic heart disease takes mitral stenosis takes time to develop. It is commissural fusion. फिर धीरे धीरे जाके जो obstruction वाले manifestations होते हैं वो आने शुरू हो जाते हैं patient में. Yeah, I mean obviously there would be atrial fibrillation in the patient subsequently as well. Agreed to that. But step one, Austin Flint severe AR, 5 सेकंड और लूंगा. Graham Steele severe PH with mild PR. Step 1. Step 2 is gap versus cam comparison that needs to be done in a patient for early diastolic murmur versus the mid diastolic murmur variant. And once you get this orientation of the gap and the cam variety, then I'll quickly draw the diagram with respect to the Caricom's murmur. So have a look at it. No need to draw it. Just getting you a hang of the fact that the mitral valve leaflets are damaged. The mitral valve leaflets are damaged. due to the valvulitis component. What I've shown at the moment is that this is not mitral regurgitation, guys. I'm not saying mitral regurgitation. I'm saying when the ventricles are contracting with force, obviously the blood will be beginning to go out of the heart, as I've shown at the moment. It will cause ये वाले जो leaflets हैं, like here what is happening is valvulitis. These valves tips are, the valve is swollen, like the valve is affected by Ashkoff nodules. So initially little bit of blood, I'll draw very thin सा, very little bit of blood can leak across here. ये जो blood जा रहा है ये तो this is during systole, but this blood will come back also ना. This blood will come back. All the little blood that will come, go up, it can also result in damage to the posterior surface of the left atria, जिसको पैथो में मैम ने आपको बताया होगा मैकलम्स पैच. याद है, आप सबने पढ़ा है मैकलम्स पैच? आई थिंक यस और नो लिख दो एक बारी चैट में फटाफट से. हैव यू रेड मैकलम्स पैच इन rheumatic heart disease in pathology? Yes, it is on the posterior surface of the left atria due to leakage of this blood from the LV to LA. लेकिन all this blood that will accumulate in the LA has to come back. वो कब आएगा? Diastole में. That is why the murmur is a mid diastolic murmur. I hope you getting the hang of it, guys. ये जो अभी मैंने दिखाया, this is like incompetence of the mitral valve. Whatever blood is going up, it is hitting the posterior surface of the left atria, so Meckel's patch is also getting created, and all this blood that will accumulate here will ultimately flow back in the phase of diastole. That is why this would be a diastolic murmur or rheumatic fever. So अगर वो rheumatic fever बोलेगा, then your answer will be different from the comparison that you would be discussing with respect to when you say rheumatic fever and rheumatic heart disease का difference is what I've tried to explain to you. अब पढ़ते हैं continuous murmur. For the continuous murmur part, the mnemonic is cannot place में हम तुम. Now you don't need to remember this mnemonic at all. I want you to remember only one entry here: coarctation of aorta. For continuous murmur, the main entry that I want you guys to remember at the moment is the word cannot place में. That would be coarctation of aorta. That is one of the core things that you guys basically have to remember, that coarctation of aorta would be having a narrowing present. So what I will also do at the moment before you is draw a small line diagram showing the coarctation of aorta. आपने chat में comment करना है what is the site. आपने chat में comment करना है what is the site, most common site for coarctation of aorta. Yes guys, waiting for comments for this one because I've been doing the talking and suddenly like मैं थोड़ा explanation mode में चला गया as a teacher, but yeah, I hope मैं समझा पाया. rheumatic fever के सवाल में और rheumatic heart disease के question में आंसर सेम नहीं होता है. Yes guys, yeah, figure of 3 appearance can be present. There could be a narrowing that is present. Very good guys. Yep, this is the narrowing which is present, the starting of the descending aorta. This would be, yeah, this is aortic isthmus. Exactly, this is aortic isthmus, and the technical word in the question would be distal to the origin. Distal to the origin of the left subclavian artery in the patient. The word will be distal to the origin of the left subclavian artery in the patient, and now you will be having is a turbulence that would be developing because there is an opening that is narrow, and at the same time there would be less blood going into the toes of the patient also. So if the blood will be going to the toes, if less blood will be going to the toes will be blue. And similarly, what you will also notice is that there would be like a substantial amount of change that would be happening. You will also notice that there would be blood that is going into the arms of the patient. The fingertips of the patient will be pink. The fingertips of the patient will be pink. The fingertips of the patient will be pink and the toes of the patient will be blue. So at this moment, what I've currently explained to you is a finding that is useful for identifying this question even without the murmur. That is by the name of differential cyanosis. Differential cyanosis is one of the good pickup points in questions of coarctation of aorta. If he says the word radiofemoral delay, super easy. But now we will focus on the murmur. इस condition में initially जो murmur होता है, ध्यान से सुनना. Initially in coarctation of aorta, the murmur will be ejection systolic because when the left ventricle will contract, because there's an obstruction also, so the patient will develop a LVH, and because of this left ventricular hypertrophy, there would be a ejection systolic murmur developing. This is step 1 of the disease. Now in the same patient, there would be collaterals. And when the collaterals will develop in a patient, due to the fact that यहाँ पे collaterals बनने शुरू हो जाते हैं, so collaterals जब बनेंगे तब what you will get in the patient will be that now it will convert into a continuous murmur in a patient. That is, it will be heard both in systole as well as diastole. So what I just wanted you to sensitize was कि आप परेशान नहीं होना अगर पेपर में if it says ejection systolic murmur in a question of coarctation of aorta, because there's an obstruction, so turbulence. But in the same patient, in the later part, because collaterals are formed and the collaterals are formed, collaterals are getting blood from the aorta. So that is gonna result in development of that continuous murmur in the patient. That's what's gonna contribute to development of a continuous murmur in a patient. So that's a very classical manifestation that I've currently highlighted before you. That is coarctation of aorta at the movement. Yeah, we can get rib notching, inferior rib notching in a patient. And let me now repeat a question of this time's INI-CET exam before you also, because couple of guys had strangely problem while solving this MCQ. So I'm also going to draw this line diagram of ductus arteriosus, and then I'm going to show a shunt reversal. Now, if you look at this line diagram, this is like the ductus arteriosus that I've shown. So pulmonary artery, what happens in patients of patent ductus arteriosus is that the oxygenated blood, which is present in the aorta, will be going like this from the ductus arteriosus to the pulmonary artery. So blood will flow all the time, both in systole and diastole, continuous murmur, perfectly okay. But in these patients, होगा क्या आगे जाके pulmonary artery hypertension will occur. Due to pulmonary artery hypertension, the pressure in the pulmonary artery will become equal to that of the aorta, and when the pressure of the two sides will equilibrate, this shunting will stop. But now the pulmonary artery pressure change is irreversible. तो बाद में क्या होगा, इस पेशेंट को जो मैं पढ़ा रहा हूँ उसको Eisenmenger भी बोलते हैं. That Eisenmenger is where the pulmonary artery hypertension will occur in a patient, and the pressure of the pulmonary artery will now exceed that of aorta. Now in this patient, the blood will reverse. और जब ये ब्लड रिवर्स करेगा, कीप योर आइज ऑन द बोर्ड, जब ये ब्लड रिवर्स करेगा, व्हाट विल हैपन इज दैट द डीऑक्सीडेटेड ब्लड विल स्टार्ट गोइंग टू द टोज ऑफ द पेशेंट. देखो इसके आर्म्स में जो ब्लड जाएगा वो तो नॉर्मली जाना है लेफ्ट वेंट्रिकल से, तो द फिंगर टिप्स ऑफ द पेशेंट विल स्टिल बी पिंक. But when it comes to shunt reversal in a coarctation of aorta, the toes of the patient will tend to become blue. Just to see you got me or not, please comment in the chat box. What is the second cause for differential cyanosis that I've explained to you? Would you like to answer PDA, or would you like to answer PDA with shunt reversal? Quick answers, please. Would you like to answer PDA, or would you like to answer shunt PDA with shunt reversal? I'll just wait for your quick answers for this one, guys. After that, we'll just take a short break and we'll resume. So yes, guys, waiting for your inputs for this one. In patients of patent ductus arteriosus, what is the cause of development or differential cyanosis? Is it gonna be a plain PDA, or is it PDA with shunt reversal? Very good, very good. I think most guys have got it spot on. It is patent ductus arteriosus with shunt reversal, क्योंकि फिर deoxygenated blood नीचे पाँव की तरफ जाना शुरू हो जाएगा. So now you know two causes of differential cyanosis, that is coarctation of aorta with PDA with shunt reversal. This question came in INI-CET exam because INI-CET के some questions sometimes get repeated. So I thought I should at least mention that before you, so that you get used to the data at the moment. So at this moment, like mammary souffle is just a filler option. That's in pregnancy, increased blood flow through the chest. Venous, some dilated veins in the chest, and peripheral pulmonic stenosis, that's narrowing in the pulmonary artery, and blood flows in the pulmonary artery all the time. So peripheral pulmonic stenosis. So these are the inputs that I would like to state before you at the moment for the current session, where I try to focus on the special pulse findings. I've talked about JVP findings, and then specifically I've spoken about murmurs. And these, most of the questions that have come in last 2 to 3 years, if you do the PYQs of your FMGE exam, you will notice that questions are revolved around this domain. So every word that I have said, it is a question. You can't say that I forgot a word. This is a high yield discussion towards the end, where like normally when you study, you can afford to miss few words, but this is not the session where you can miss a few words. So this is the message at the moment. Yeah, MRA is the investigational choice for this condition. So what we will do is, guys, we'll take a short break and we will resume in the app again. Routine discussion will continue. That would be at 3:30 onwards. So at the moment, just a quick break, water and a bit of recharging that I need to do. And we start at 3:30 at the moment. Yes, Somajit, you will be doing great. My blessings are always with you, and I'm gonna stay with you over the next 3 days. So I'm gonna keep on hammering and drilling facts in your brain, and with logic. I try to do it with logic and with rational and with my heart, so that when what I went through when I was in medical school does not happen to you guys. So what we will do is, Shachi, you need to, like, let's do it in the evening, man. Let's do it in the evening, man. So class will be till 8 o'clock, man. 8 o'clock, 8:30 at least. We'll try to do a lot of concepts for today. So please hold on. So 3:30, guys. Just let's refresh. And sir, beta, enough to kuch bhi nahi hota. Enough to kuch bhi nahi hota. So I think we can meet again at 3:30 very soon, guys. Class will be till 8 o'clock, beta, at least, and will go on till approximately 8:30. And I'll keep on hammering and drilling facts with logic in your mind. Take care. God bless you.